Now, we now come back to Andy Shennan, who is going to present an update on the CRADLE clinical trial. When he's presented before on that, but this is now giving us an update. Plus, I'm quite sure, a wider range of topics. Thank you very much, Andy.
No, thanks, Jimmy. I'm actually going to devolve this responsibility to Alice Beardmore-Gray. Just, Marcus suggested that we might give an update on the global work. So I just want to very briefly, maybe in three or 4 minutes, share with you some of the ongoing work, really to get appetite for the future. Scarlett Baker, one of our team, very kindly put the slide together, and it was interesting looking through all the projects that are ongoing now in low and middle income settings from our group, with a view to kind of the importance of pre-eclampsia. So very briefly, the Two Young Lives program, we've realized that teenagers are a phenomenal part of the problem. As it were, the 40% of maternal deaths in places like Sierra Leone are in teenagers. And the solutions there are very relevant because they get much more preeclampsia and worse outcomes. Papaya is funded by the Fetal Medicine Foundation, and there's looking, Alex Ridout's leading on that, and is looking at low-dose aspirin, amongst other interventions, targeting early kind of antenatal care in very challenging environments, which I think is key to changing outcomes. And again, preeclampsia is a big part, slice of the cake. CRADLE Smart, the FCDO, is looking at point-of-care testing in many areas in Sierra Leone and Zambia. And again, preeclampsia, a big part of that, and we're persuading the Foreign Office that this is worth funding. Papaya is ongoing, looking at angiogenic markers and point-of-care tests across in South America, India, and Africa. CRADLE B is looking at postpartum detection of morbidity to try and ameliorate long-term cardiovascular disease in a low and middle income setting, which I think preeclampsia and hypertension is such a good marker of future problems that it's a great way to do that. And Alice Beardmore-Gray is working on Empowered, more to do with sort of picking up issues around long-term kidney problems. And then Candice is looking at CARES, which is in Sierra Leone, predicting issues in teenagers and preeclampsia. So it was quite sobering looking at all this across the board and thinking, well, preeclampsia is a big part of all the problems we're dealing with there. But actually what I really wanted to do was distill the importance of looking further at your data once you have it. And many of you will know the Phoenix trial, where we delivered women routinely from 34 weeks with preeclampsia in the UK, and showed that, not surprisingly, maternal outcomes were improved, but baby outcomes we couldn't really evaluate, simply because no babies died, whether they had an intervention or not, in 900 early onset preeclampsias. And we more or less repeated the study in Zambia and India, where actually we were able to evaluate, and this was published in the Lancet in 2023, the Phoenix in 2019. And the data sets were very rich. Just to very briefly summarize, what we demonstrated was just for delivering 33 women sort of routinely, as opposed to waiting for a crisis, we could prevent a stillbirth. So in terms of numbers needed to treat to prevent a problem, that is very much in our comfort zone. That's much better than what we do for post-AIDS pregnancies, for example. And it's, simple, cost-effective, and I think very, very exciting. But what I really wanted to do was give you an example of looking at your data once you've collected it and to get other answers. So clearly delivering early looked to be good for mother and baby, but we also wanted to look at long-term morbidity. And so one of the things we did was look at the kidney function in these women in these trials. And I'm really going to hand over now to Alice, who's been looking at this along with Catherine Clark, one of our midwives, and I thought that might be interesting to share with you. So Alice, if I can pass over to you, that would be great.
Yes. Hi, everyone. A real pleasure to be here. I'm just going to hope that I can share my slides. And thank you, Andy, for a very nice introduction. So I think that should be sharing.
Yep, we can see it, Alice. Thanks. Just head to full
Great.
screen.
Is it showing as a slideshow, or let me just try and present? Yeah, perfect. There we go. Great. So as Andy just said, we wanted to take the opportunity to have a look in a little bit more detail at some of the more granular outcomes, combining data from the CRADLE-4 and the Phoenix trials, and also comparing kidney outcomes between high income as well as low and middle income settings. So this was a piece of work led by Catherine Clark, who's just completed her PhD, focused around pregnancy-related acute kidney injury, who sadly isn't able to present today. With my input from the CRADLE-4 perspective, our wonderful statistician Paul and Kate Bramham, who is a nephrologist and an expert in pregnancy-related kidney injury. As well as obviously everyone else who is involved in both of these trials. I'm going to try and keep it brief because I see that there's a break coming up at 4 and I don't want to eat into your tea time. But this is really just to try and, I suppose, highlight this really vicious cycle between pre-eclampsia and both short and potentially long-term kidney damage. So we know that around the world, a woman dies every 2 minutes during pregnancy or childbirth, and that the vast majority of these deaths are preventable, and the vast majority of them are occurring in low and middle income countries. And you can see on the right there, the most common causes for maternal mortality with PPH and hypertensive disorders, including preeclampsia, being the leading causes worldwide. What we also now know is that for every loss related to preeclampsia, at least 50 to 100 women will also experience substantial morbidity. And actually the global burden of life-threatening maternal near-miss complications now outweighs the burden of maternal death. And when we think about what is that morbidity, well, kidney injury is one of the most important consequences that we see. And this was from a review, you can see the reference below, published in 2022, showing that preeclampsia is now the leading cause of pregnancy-related kidney injury worldwide, and particularly within the sub-Saharan African region. PPH and infection are other really important causes as well. Why does it matter? Why do we care if a woman develops an AKI? Well, this was some work done actually as a secondary analysis of the CRADLE-2 trial, I believe, by Fran Conti-Ramsden in 2019, looking at the proportion of women who are hospitalized with preeclampsia that develop an acute kidney injury, and the association with maternal mortality as well as perinatal mortality, and then also the proportion of women who recover afterwards. And actually many of these women were discharged without knowing whether or not their AKI had recovered and without any follow-up. So there's a big knowledge gap in understanding what happens to a woman post AKI, and that's part of the current work that we are working on as a group. And then on the right here, you can see that it's not just the current pregnancy that gets affected, but actually this study published in 2018 shows that even if you have had a recovered AKI, it increases your risk of subsequent pregnancy complications, and particularly preeclampsia. And then again, looking at what we know about the long-term effects, we can see quite a significant increase in cardiometabolic adverse outcomes associated with women who've experienced an AKI. And I think, you know, a lot of this is retrospective data, secondary analysis data. There's potentially a huge burden of disease out there that we are currently unaware of and have underestimated. And I think this just really highlights the need for all of the current work that's happening and good quality prospective studies. So moving on to what we looked at specifically between the CRADLE-4 and the Phoenix trials, Andy's already given a very nice summary of both of these trials. Essentially, they both looked at timing of delivery for women who have pre-eclampsia without severe features between 34 and 37 weeks. Phoenix showed a significant reduction in the risk of maternal complications associated with planned early delivery, with an increase in neonatal unit admissions, but not neonatal morbidity. And CRADLE-4 found very similar results, but with quite a striking reduction in the risk of stillbirth in the planned early delivery group. And again, given that this was done in much higher risk settings with a much higher burden of disease, you can see the difference that context can make. The aim of this secondary analysis was then to look in a bit more detail about whether women who were expectantly managed experienced or whether that affected the risk of kidney injury as reflected by the highest recorded serum creatinine. And then subsequent to that, to look at the association between serum creatinine and the maternal and perinatal outcomes, as well as looking at the difference between the two settings. So we looked at all of the women who were included in these trials. They needed to have at least one serum creatinine recorded on the study database. And then we looked at a smaller composite outcome than the main trials based on the availability of data. So you can see that there. And then you can see here the numbers that were included, and you can see, so remembering that in total in CRADLE-4 there were 565 women included in the trial, you can see that quite a significant proportion of women didn't have a creatinine recorded at all. And that really just demonstrates the scarcity in terms of being able to actually detect complications. And this was particularly a problem in Zambia, where often there simply aren't lab resources available. And so again, you can see that there's potentially a hugely underdiagnosed problem here. So what we looked at was we looked at the worst, so the highest creatinine that was recorded. And you can see here that in the expectant management group, there was a significantly higher, worse creatinine. And, you know, I think that this is to be expected. It makes sense because women in the expectant management group were managed expectantly until either they developed a complication needing delivery or they reached 37 weeks. But sorry, someone at my door. I think what this really highlights is that, you know, often people will think that by managing expectantly you can gain more time, and that, you know, this woman is going to escape complications, whereas actually what we're seeing is a large proportion of women will deteriorate and will need emergency delivery, and that is having a potentially significant impact on their kidney function. This is now looking at the difference between the two studies. So this is CRADLE-4 on the left, and this is Phoenix on the right. And you can see that the worst creatinine was again overall higher in the CRADLE-4 population compared to the Phoenix population. And that's just showing the numbers there. So again, kind of confirming what we already know, which is that the burden of pregnancy-related AKI is higher in low and middle income settings because of a whole host of different reasons. But often these are women who are presenting later and with more severe disease. So there's work to be done there. Looking at the association with our maternal composite outcome, again, as you might expect, the highest creatinine was higher amongst the cohort who experienced the maternal composite outcome compared to those who didn't. And then looking at the individual components, this was significant when looking at placental abruption. And again, I think, you know, we would expect this to be the case, but I think it's really important to think about what that means in terms of the longer term outcomes for this woman, her longer term kidney function, her future pregnancies. And so, yes, although we expect an association to be there, actually, if we can intervene earlier, if we can deliver these women before they become sick, we're potentially reducing not just short-term adverse outcomes, but also future cardiometabolic events as well. And again, this is looking in a bit more detail at secondary maternal outcomes. And again, we can see the same pattern with particular associations, again, with outcomes that you might expect, such as severe hypertension, ICU admission, and PPH. There wasn't a significant association found with the overall perinatal composite outcome, but again, some associations seen with individual components, including the need for respiratory support, SGA, and low APGAR scores. And again, I think this correlates with what we see happening clinically, which is that women who have a higher creatinine have deteriorated, they've experienced more severe disease, and therefore we would expect that their babies might also experience more adverse outcomes. And this is again then just demonstrating the differences by study and by country. So these graphs taken me a while to get my head around, but essentially we're looking at something called geometric means. And so the higher peak at a lower creatinine value here means that on average, women in the Phoenix study had a lower worst creatinine compared to women in the CRADLE-4 study. And this was largely driven by women in Zambia, which again, I think just demonstrates the severity of the disease burden in lower income settings and the challenges there that we really need to address. And I think, again, that sets up the work that we're currently trying to do with both Empowered and CRADLE-B, is then trying to understand what happens to these women postnatally who have experienced a pregnancy-related AKI and then actually potentially have no follow-up and no access to sort of ongoing renal care in the community. So it's a little bit of a whistle-stop tour, and this is all hopefully will be published as soon as we can get the manuscript written up. And I think that it's just demonstrating that planned early delivery may protect kidney function, both in the short term, but also the longer term. And that's really, really important when we're thinking about women's future health across the life course. It demonstrates that the highest recorded creatinine is worse in a low income setting compared to a high income setting. We really need to think about where we're targeting our resources and our funding, and that a higher serum creatinine is associated with adverse maternal and perinatal outcomes. So, you know, I think the other thing is, if you're looking after a woman or a baby that's sick, make sure that we're looking for the AKI as well, and ensuring that that woman has appropriate follow-up and care. Obviously, this is a secondary analysis. We need longer term follow-up data. We need better pregnancy and gestation specific creatinine thresholds to improve the way that we're diagnosing pracky. We need improved lab resources in low and middle income countries to improve the detection of pracky. And we need better evidence around what can we actually do about this once we have picked it up. So what are the early perinatal interventions that we can put in place to reduce the long-term sequelae? And this is just the full references for both of the trials here, and a long list of thank yous to everyone that was involved. And if we have time for questions, I'm very happy to take any.
Thank you very much for that, and a very interesting study. There are no questions at the moment in QA, so I'll take advantage of jumping in with two questions. One is that it's always been a slight worry to me about the diagnosis of AKI in the postnatal period, because, as you know, there is normal rises of creatinine following delivery in pregnant women. So are we over-diagnosing AKI in pregnant women, or is that being taken into account? And the second question is that, as being probably one of the leading advocates of prolonging pregnancy over the last 40 years. Are you now telling me that I've been doing damage to women by prolonging their pregnancy and therefore maybe making their AKI worse and the long-term health worse?
So yeah, well, on the first question, are we overdiagnosing it? I think that, I mean, overall, so some of the work that Catherine did during her PhD was looking at the gestation-specific thresholds, and actually, I mean, this is antenatal, not postnatal, but I think a creatinine of 55 is above the 95th centile of what we would see in a sort of normal, healthy pregnancy. So I think overall, if anything, we're massively underdiagnosing AKI. I think that in this particular study, looking at the timings of when the creatinines were taken was quite a challenge, because, you know, we were not collecting it at set time points necessarily. So we had a look at what the biggest difference was, and whether it made a difference, whether it was an antenatal one that was taken on the day of delivery or one that was taken postnatally. And the biggest difference was on the day of delivery rather than postnatally or antenatally, which I think also makes sense given that the planned early delivery group were obviously delivered at a point where they were hopefully relatively well, whereas the expectant management group, women who had a creatinine on the day of delivery, were usually quite sick. But I
can answer the next question, so you don't have to criticize Jimmy if you like.
Well, okay, I'll let you answer it then.
Yes, Jimmy, you've been.
Yes.
Thank you.
But joking aside, you know, kidneys are pretty important. I don't think obstetricians really get that. I mean, I know they do, but what I've learned from this work is that long-term problems are massive, especially globally. You know, 15% of the women we had in South Africa had long-term, you know, recognized kidney damage, and it is a window of opportunity to prevent it with a view to improving long-term health. And I think it's an area that's slightly kind of been missed, particularly the fact that people just don't measure creatinine most of the time. So it's something that I've learned. I've got over the fear of kidneys, and I'm starting to realise they're quite important to do something about them.
And I think I also didn't, until I started doing this work as well. I had no idea. You know, I thought, okay, well, you develop an AKI and then it gets better, and so what? And I didn't appreciate the long-term effect of that, even if it has recovered, and what that means for, you know, a young woman who might go on to have 3 or 4 further pregnancies. So yeah, I definitely didn't appreciate that until we started looking into it and working with Kate and Catherine.
Just before I bring Kate in, just another point is that in previous studies have shown about 25% of women who present with severe preeclampsia probably have underlying kidney problems to start with. So it's again, what's chicken, what's egg is always a problem there.
Yeah, and no one has a baseline creatinine recorded at the start of pregnancy, which is.
I mean, Jimmy, I think the fact that delivering earlier makes it better sort of suggests chicken, if you know what I mean.
Okay, Kate.
Thank you. So taking that question on, Phoenix was set up to do medium-term follow-up of the babies to see how they coped at 3 to 5 years. I don't know whether it'd be possible to actually do something similar with the mothers, albeit retrospectively. We've got this cohort of women who are randomized to being delivered immediately or have expectant management. We're now getting on for coming up to 10 years since the median time for that study. Would it be possible to see whether or not there's any impact on their creatinine in the medium term?
I think that's very, very difficult just because of the follow-up. You know, our follow-up for 2 years was quite challenging. We did the 6-week cardiac follow-up in Phoebe, which was also not easy. To get everyone at 10 years would be difficult, but highly desirable. So I think in the future, this data linkage is going to become important.
And I think that's what we're hopefully trying to achieve with some of other international research studies. So Papagayo and CRADLE-B, and Papagayo is looking at, you know, there will be a timed delivery intervention incorporating PLGF, and then CRADLE-B is following women up only to 1 year. So, you know, not ideal in terms of it would be lovely to get the much longer follow-up, but that's part of what we're looking at now is at a year postnatal, what are these women's creatinines, what are their blood pressures, and looking at other cardiometabolic outcomes. And part of my current work is trying to understand how logistically can you facilitate that follow-up in settings that are, well, it's challenging everywhere, but yeah.
Okay, thanks very much. I'll stop now since my reputation is now in tatters.